Thank you. Good morning. I'm very happy to be here and be in person this time. So my topic today is quite broad because it includes treatment, but also early intervention in food allergy. These are my disclosures. The only relevant for this talk is I was an investigator for Immu, which is the company that developed the product for or the treatment for peanut allergy. So I will be covering both topics, oral immunotherapy in particular within the field of allergen immunotherapy for foods, but also early interventions. So the early guidelines from 2020, what LEAP study brought, or what we found with LEAP study, and the current guidelines. So there's a common belief that food allergy is increasing, and we have studies from all around the world. And we know the incidence is around 10% of the adults, a bit higher for children, but there's a very large variation between different regional areas. So for example, in Europe, in Europreval, we found that 2% in some areas and close or over 20% in other areas. It's particularly interesting the case in Australia, where with a food challenge proven, 10% of the children of 12 months of age were allergic to foods. So we know food allergy is important, but we don't know the evolution. We don't know if this is increasing. What we do know is that severe food allergies, so food allergy reactions that take the patient to the emergency room or potentially kill the patient, are increasing. So, and this has been seen in all the series that have evaluations at different time points. This increase is particularly larger in younger kids, and those foods that cause the highest increase is egg, milk, and nuts. So many researchers over 20 years ago thought or came up with the idea of treating food allergies in the same way we were treating respiratory allergies, so through immunotherapy. Some of the initial approach were subcutaneous routes, but also oral, sublingual, more recently epicutaneous, but we have most of the data from oral immunotherapy, so I will be focusing in oral immunotherapy. So most of the patients will react with low amounts of foods, as low as 125 milligrams. And the target of this treatment is to increase the reactivity threshold, so to desensitize the patient, so it couldn't react with small amounts, or eventually they will be able to tolerate a serving dose of the food. There are different protocols out there. Pretty much every center has their own protocol, but most of them have 3 different parts. So there's an initial dose escalation that always comes and it's mentioned that we need to do a baseline evaluation. So we need to be really sure that the patient is allergic to that food for all the things that we have mentioned before. Sometimes the diagnosis was not properly done, so we need to be sure that the patient reacts to the food. So after that initial evaluation, we have a first dose escalation dose, which is in 1, 2, or a few consecutive days. And after that, we have a build-up phase. So during this build-up phase, the patient will come to the clinic once per week or twice per week, and in between these visits to the clinic, they need to keep having the same tolerated dose at home. And this is very important for achieving a good result. And then once we reach the maintenance dose, the patient needs to stay on daily consumption of the foods. For certain foods like egg, we can do every other day, or we can have a more adapted schedule, but basically the patient needs to stay on the food. There are some studies trying to look at if this is a permanent treatment, or the patient is just desensitized, meaning if after stopping eating the food, they will react again to the food, or this is a sustained effect. What we know so far is this is temporary for most of the patients, so it's really important that they keep having the food at home regularly. IACI was the first organization to come up with guidelines regarding food allergy immunotherapy. And this was based on a meta-analysis that they performed before. So these guidelines have recommendations only for 3 foods, and with a strong evidence to recommend as effective treatment. And this is for egg, milk, and peanut. And these recommendations, as today, are for kids older than 4 or 5 years of age, and only for children, but not for adults. And there's a lot of new publications after these guidelines, if we should start treating the kids earlier, or what happened with adults. Should we start adults in oral immunotherapy? But the evidence we have, the studies, the clinical trials that were done were mostly in this group age. So we have strong evidence in this group age for, as I said, milk, egg, and peanut. And no evidence, there are only very few reports for adults. So this systematic review didn't find any difference among the foods. So this treatment is equally effective for milk, egg, and peanuts. And they didn't find any difference between protocols. But the truth is that we don't have an answer. What's the proper regime? What should be the interval between doses? How fast we should upscale? So there's still a lot of questions that we need to answer. Another different approach was this medication called Parforcia. And the target of this researcher was not to reach a serving size of the food, let's say for milk, 1 glass of milk, or a full egg, or a full omelette, but to prevent kids from having accidental exposure. So the target was they were able to tolerate 2 peanuts. So the posology, or the treatment is exactly the same. So an initial dose escalation followed by a maintenance dose. What they found is most of the patients were able to tolerate 300 milligrams or 2-3 peanuts, but only half of them were able to tolerate higher amount of peanuts. So this treatment is effective for preventing against accidental exposure, but not to really be able to reintroduce the food in the diet. There's a lot of questions, a lot of debates about the safety of these procedures, and it's true that the kids that go through this have reactions. We don't really know the incidence because most of the studies will report adverse event differently, but we know the most common side effects or the most common reactions are either anaphylaxis or gastrointestinal symptoms. We know that there are certain patients that are at higher risk. So patients that previously had anaphylaxis when having the food, patients with asthma, or those patients with a low reactivity threshold. So patients that react with traces or with contamination of the food. And we have a particular age group that is very tricky, and those are teenagers, as for any other medical conditions. So it's very important to individualize the protocol, the increases, the duration of the protocol. For some patients, we might need to get or to achieve a different target dose. And for certain patients with more severe reactions or not tolerating the treatment, we might need to add omalizumab. There are different cofactors, recommendations we need to do to the patients. The dose need to be taken regularly, and this is particularly important at the beginning of the treatment. They shouldn't have the dose on an empty stomach, so we need to advise them to eat before coming to have the dose, or when they are at home, they need to eat before having the dose. They need to be particularly careful, and we need to give instructions for when they have infections. This is very common in kids, colds or gastroenteritis. We need to advise on medications, so particularly with ibuprofen, non-steroidal anti-inflammatory medications. They should use only acetaminophen. And the most important thing is in those kids that have asthma, asthma should be perfectly controlled. And that's probably the most important thing to prevent reactions to the build-up phase or even later during the protocol. So some patients might not be able to identify their asthma symptoms or their asthma control, but if we really evaluate and we really look into it, we find out that these patients are not very well controlled. So when we select a patient to this treatment, to initiate this treatment, we have a very important role. We need to identify the proper patient, but the family and the kids themselves have also a really important role, because this treatment involves or implies lifestyle changes. They need to, for example, those kids that exercise or do sports, they need to adapt their practices to the dose. They need to be able to understand that they might have reactions that they need to treat at home. So it's very important to do proper baseline screening, and I really recommend that all the patients need to do a food challenge at the beginning. And as mentioned, there's a lot of lifestyle adjustment in sport, extracurricular activities, and for some patients, we need to evaluate comorbidities. And another important thing is all of them need to have a written treatment plan. So moving from treatment to early interventions, we know that severe reactions are increasing, probably food allergy is increasing, but where does this come from? So we had for over 20 years guidelines in place saying that allergenic foods should be avoided, and we should introduce some of these foods very late in life. And this all changed when this study was published. Most of you might be very familiar with it. And this was the LEAP study that was published in 2015. So this study, they allocate the kids, they randomize the kids to either early introduction of peanut in the form of snacks of peanut butter, or to avoid peanut and introduce later in life, as it was commonly done back then. So this is not, it's very small letters, but so for those kids, another thing that they did is when they recruited the patients as initial evaluation, they tested if the kids were sensitized or not. So they have a positive skin prick test to peanut, even peanut was not introduced, or they had a negative skin prick test. So in both groups, in sensitized kids and non-sensitized kids, all of them benefit from an early introduction of peanuts. So it was beneficial in both groups. In a subsequent analysis, they look at kids' ethnicity, and this was a positive intervention in all ethnicities, not just in white kids. And when they follow these kids later on, they found that there was a sustained effect. So after being on peanuts for 5 years, if peanut was stopped, this effect will be maintained. So this was a very important study in realizing that maybe we were doing things wrong and we should reintroduce foods earlier in life. So the current guidelines show that peanuts should be introduced much earlier in life. There are certain discussions in which kids, if all kids, all countries, or only kids at risk, only countries where peanut is consumed. And cooked eggs should be introduced very early in life as well. Regarding milk, this is we can discuss now, if you want, is a really hot topic because of breastfeeding. But what is really, it shouldn't be done is a temporary supplementation of milk during the first week of life. That should be completely avoided. And that's it. All other interventions that have been tried, we don't really have enough information to see. So basically, peanut, boiled or cooked egg, and not temporary administration or supplementation with milk. And this should be all for today. And thank you for.
Thank you.